Good afternoon, everyone, and welcome. And thank you so much for choosing our session. We've got you guys in the room with us, which is absolutely fantastic. And welcome to our guys who are joining us live streaming online. We've got a fantastic array of presentations this afternoon. I'm Mandy Andrew. I work with the Health and Social Care Alliance Scotland, and I'm also a Senior Associate with IFIC. It's absolutely great to do these sessions, and it is all about knowledge sharing. And this is such an important subject that we're starting to talk about this afternoon with our focus on homelessness. Before we start, I'd like you just to take a breath and have at the back of your mind, what are your take-home messages from your learning from the session? And I ask you to think of either 1 to 3 points that you will then go at some point within the next week and share with somebody else. Because this is how we are going to continue our network of sharing. So we have 6 presentations. Just to say to you, our format this afternoon is we're going to run through the presentations. We're going to have myself, then our second presentations, our next 2 presentations, we have the lovely Michelle and Michaela, who are going to come up and do a double act as well. Then we're going to be followed by our very own Alejandro, and then by Vanessa, and then we're finishing off with Isla and Lynn. For all the guys online, pop reflections into the chat box, pop your questions into the chat box. They'll all be monitored as well. At the end of the presentations, we'll ask all the presenters to come up onto the stage and we can have a cosy Q&A session as well, with the aim that we finish sharp on 6 o'clock. So I step out of that role and I step into the role of Mandy Andrew, your first presenter. So welcome. Now, hang on. Very important to have the little button to be able to press forward. I have a short presentation to share with you, and it would be interesting just to hear your reflections at the end. I want to speak to you about the Big Scran. In Scotland, Scran is a local dialect for food. And this is about an initiative that came up through a very dear friend of mine, Tricia McFarlane, and her husband Ian. And it was the initiative for it was the downturn in the economic climate, living in one of the most deprived areas of Scotland, West Dunbartonshire, and really beginning to understand that there were people who were going hungry and what could they actually do about it. So I, along with others, am a founding volunteer of the Big Scran. As I say, it came about through Tricia, who actually is a trustee of Benview, which I'll tell you about in a moment, and Ian McFarlane, who's the chief exec of Blue Triangle, which is a large organisation which focuses on supporting the homeless in Scotland. And Alison McCurley, who is Benview's resource manager. Benview is a resource centre and has a leading community anchor organisation in Greater Glasgow and Clyde Health Board area. That's the largest health board area in Scotland. And Greater Glasgow and Clyde is also the most deprived area in Scotland as well. And Benview have been looking diligently over the last 2 decades of co-designing and building a volunteer movement across West Dunbartonshire. Blue Triangle, the organisation I mentioned, is the largest homelessness organisation in Scotland, whose mission is to empower to thrive by delivering solutions in connected communities which focuses on the needs of the individual. And this is at the heart of the Big Scran in Dumbarton. Right. Sorry, Michael, brilliant. Lovely, thank you. Benview Community Resource Centre is in partnership with us to actually take this forward. But also as well, we've brought together the West Dunbartonshire Health and Social Care Partnership as well, and created a volunteering movement entitled the Big Scran. The purpose of the initiative is to provide essential practical support, food, heat, interaction at a time when our world is detrimentally affected by the global financial crisis and rising cost of living, by providing a weekly community meal in a psychologically informed environment. We use co-production methods to gently, and that word gently is really important, to shape the activities and agencies which should be involved. Everything from food being served to partners involved has been shaped by the voices of lived experience from the people who attend every week. In tandem, the partnership has addressed wider needs affecting generational changes for individuals and families, such as maximising income and supporting delivery of health outcomes as well. For your information and to add a little bit of national context, in December 2018, Scottish Government launched its strategy for tackling social isolation and loneliness, defining the vision of a Scotland where individuals and communities are more connected and where everyone has the opportunity to develop meaningful relationships. But this is against a backdrop of the global financial crisis, as I mentioned, and complex public health challenges facing the community, such as gender-based violence, substance misuse, youth homelessness, and other population themes in partnership, including Blue Triangle and the Health and Social Care Partnership as a force for good. Their approach addresses immediate needs, hunger, heat, social interaction, and affects the change, taking a person-centred and trauma-informed approach, building individual relationships, leveraging the skills and talents and local knowledge of volunteers, supporting translation of needs assessments into meaningful interventions. Against all the social determinants of health, West Dunbartonshire fares poorly internationally. The burden of depression, anxiety, mental illness, substance misuse, alcohol dependency, smoking, and interpersonal violence are key drivers contributing to our burden of disease, more so in West Dunbartonshire. The impact of social isolation and loneliness, as I'm sure this is a topic that touches on all of the work that we do, on the individual's physical and mental well-being has been well documented. It increases the risk of stress, anxiety, depression, and doubles the risk of dementia. The Health and Social Care Partnership understands that the status quo is no longer an option, and that building a resilient, compassionate community of people is essential to tackle the complex social justice challenges facing the population. The thought leadership from this initiative builds the compassionate community by creating and producing a new volunteering movement. In partnership with service delivery organisations and the Health and Social Care Partnerships, which carries the statutory duty for health and social care. The relational approach of health improvement by creating a volunteering movement of local people. And that's something that has actually been so important. It's local people. This has not been a job description or an advert. There was a call that went out and people all came together for an information evening where we sat down, where we introduced ourselves. We didn't come with some big fancy titles or this is how many ologies I have. This was about being the person and wanting to help, having an open mind and an open heart. Creating this volunteer movement of local people supported by known and respected local organisations building the community resilience required during the harsh global financial crisis. The success of this initiative has been such that other communities are now launching their own Big Scran in other areas of Scotland, utilising the learning and success of the Big Scran Dumbarton. So, for example, here on our logo, we have Big Scran Dumbarton. So to show you what the types of volunteers, we had somebody who joined us who was actually a marketing, had worked in marketing. And through her contacts, they designed our logo. And that actually cost nothing. It was at the point of being able to actually give and contribute. The Big Scran's processes and assets have been created to be transferable and scalable to all communities, not just in Scotland, but beyond. Other communities across Scotland are using this model and their assets to build similar partnerships and volunteer movements in their own areas. This fits with the policy landscape in Scotland and beyond, and its desire to create and connect compassionate volunteering movements across Scotland and globally. The success and impact of the Big Scran movement is informed and sustained by the people's needs, and all involved, recipients and volunteers, positively gain from this model that can be replicated. The one thing I would say around the co-production, we didn't go in straight away and say, right, what would you like? What are the additional things that you would like to see? What would you like to be included? What we did was we started with a meal where people came in, sat down and were served that meal. And we sat and had that meal with them and listened to their story. It was exceedingly humbling. It felt like a sliding door moment. And that's how I described it to somebody. It depends, it was just so happens the way that the dice had fallen. I thought it could be so easily me sitting on that other side of the table. And the stories that people came with were actually eye-opening. But also as well, what came across was sometimes these were people that fell through the cracks. So initiatives that came up around the benefits that were coming out to support people that they could claim, we then ended up with somebody from the local Citizens Advice Bureau coming, and is now coming once a month, to ensure that everybody is getting the benefits that they are entitled to. And interestingly enough, what people are saying, despite all the adverts, despite everything that has been done, they didn't know that that was actually that they were entitled to that. So finally, looking to the future, the Big Scran has been so successful that we have outgrown the venue at Benview Community Resource because we now have between 50 to 60 people attending each week, plus partner agencies and volunteers. We're in talks with other organisations, including the local football club, who have community assets and wish to utilise them. It's exciting times ahead, and let me just go forward. Yeah. Can we go to the next one, Michael? Right, there we go. So there's lots that we can do. We would love to share it. If anybody would like information on how to replicate this, how we got started, please do get in contact with Tricia. The idea of being able to share this today has been absolutely fantastic. And it is that building that connected and compassionate community through a volunteer movement. Our philosophy is that when an initiative is this successful, it's our mission to share the model with others who might wish to build their own connected, compassionate community. And Tricia would be delighted, as would I, for you to connect with all the founders to find out more. Thank you very much. So Now I take off the hat as a presenter and come back into chair mode. Without further ado, I'm really delighted to welcome Michelle and Michaela and Joe onto the stage as well. Good. Over to you, ladies.
Thank you, Mandy. I'm just going to practice with this. Oh, there. Okay. Right. Good afternoon, everybody. In this presentation today, we're going to share some of the preliminary findings from an evaluation we've been doing of the out-of-hospital care models programme for people experiencing homelessness. And I'm joined here today by my colleagues, Michaela and Joe. And Michaela leads on the sort of the quantitative and economic, the very clever side of things for us, the numbers. Joe leads on all our sort of co-production and lived experience work, and any questions in that, Joe is going to answer those. As a research team, we've been working together now for over 10 years, and our job in this 10 years has been to try to prevent the practice of discharging homeless patients to the street. So for 10 years, we've been trying to improve hospital discharge practices for people who are homeless. And I actually first met Joe, didn't I, on a cold, wet November night when Joe phoned to say, Michelle, I've been discharged. And there was Joe sitting in the lobby of the hospital in her slippers, in a nightie, in a dressing gown, with your bag of medication. Could you open your medication?
No, I couldn't open the medication because I'd had the operations on my hands, because I had the finger amputated because I was attacked when I was on the streets. And I couldn't push the tablets out or anything else. And I was also on a gutter frame that you're not supposed to use out on the street. It's dangerous. And I couldn't even get up and down off the floor, you know, so...
And you weren't, no blanket, nothing,
no
pyjamas?
Bag, no blanket. I'd been in hospital for about 6 months by that time. And, yeah, I had nothing, you know.
It was the most hideous experience. And unfortunately, back in 2012, this was not an isolated incident. It was fairly standard practice in some of the big hospitals that when homeless people were fit, you were out on the street. That was it. You know, they make some efforts, but generally, here's a post-it note, off you go to the council. Thank you very much. And one of the first projects we actually did, it was a great big £1 million study by the National Institute of Health Research. And we were able to show that across England, there was a few very rare services which when somebody came out of hospital, they provided them with, you know, a house. It was a unit, Bradford. It was a lovely step-down facility. And for 6 weeks or longer, they did all the work really that should have been happening in the hospital. The nurses in the hospital at Bradford would come out and keep in touch with people. And it was a really good model. And that's what I say with Michaela and guys at UCLH. We were able to show with the hospital data that it not only made things nicer for people like Joe, but we showed lots of the big things that the commissioners like, that we could reduce hospital readmissions, well, it was A&E reattendances by 14%. So really everybody, the Department of Health, everybody's ears pricked up at that because, you know, little voluntary projects get the chop, don't they, unless we can do this. On the back of that, NICE, the organisation in England that makes recommendations, picked up on this, and they said these schemes are value for money. Commissioners, you must now develop them in your area. And the Department of Health then allocated £16 million to 21 test sites across London and England with the challenges. We know what is effective and cost effective. Can you go out and roll this out in your area? And we've been commissioned really for the last 2 years to look at how successful, how have local areas been able to roll out the model and to prevent discharge to the street. And one of the key objectives, and what we're going to talk about today is a little bit, is how these models are being integrated into health, housing and social care systems. Now, just in another little bit of background, one of the impacts of COVID in England was to wipe away all the old hospital discharge guidance. And a new model was introduced, which is called discharge to assess. So there's the person, you're in a bed, you're clinically optimised, that's not your package is ready, it's you're ready to go, you will leave hospital and all assessments will take place in the community. And there's 3 pathways. One is get everybody home at all costs, home first, with the reablement teams. Residential step down, you don't need a care home, but an extra care facility somewhere in between. And as a last resort, you might end up in a care home. But this policy really is designed for older people. It's got older people at the forefront. And one of the things, a bit of the achievement of our NIHR research was we got the policymakers to tell commissioners in that new operating model, these models are not just about older people. People who are homeless need intermediate care too, because people like Joe, you've got mobility issues, you know, isn't it? Lots of long-term conditions. You need as much support. Yeah. So that was the model. And basically what we tried to do in these test sites was to get the test sites to integrate as part of this older people's service. And that was the challenge. In terms of the methods we use for the evaluation, we've got a big quantitative side going on. We tried to replicate, there's a national intermediate care audit framework, which has sort of lost a bit of favour, it's gone out of sight, but we use that to look at the effectiveness of specialist homeless intermediate care services. So we were doing EQ5D, person comes in, baseline, person leaves. Joe's work has done a patient experience measure. So Joe interviewed everybody going through these things. Scale. We're looking at trying to look at hospital statistics, service delivery costs, and getting projects to monitor what they do. What is your length of stay? Are people getting stuck because there's no housing? Yes. The piece of work that I've been leading on was a study of positive deviance. So we looked at the audit data and we said, what are the 3 best performing projects in there? And then we targeted all the qualitative work to learn from those projects. And in times of austerity, positive deviance, appreciative inquiry is really important because services are austerity commissioning. They don't want a bad word or any negative light shone on them. They're extremely defensive because if you're not seen to be the image to commissioners is everything. So this approach was a lot of building trust. In terms of the findings, 2 years on, what have we seen? Well, the reality is the projects, the 21 test sites have really, really struggled to implement, to embed specialist services in wider intermediate care. We do have some outstanding exceptions, and Cornwall, which is a beautiful part of England, down south, it's like got the coast, the sea, it's a beautiful area. They really managed to implement all this guidance to a very high degree, high fidelity. So in the hospital, they had a homeless advisor working with discharge nurses in the hospital, and she was a part of the the OTs, the physios. Jenny, she'd be going out, any homeless patients, she's on the phone, sorting out housing, other issues. Anybody comes in with a heroin or a crack addiction, she's on it straight away to get opiate replacement because we don't want people. Delayed discharge is not a problem for people who are homeless, it's early self-discharge, getting out there because you're crackling, aren't you? If you came out of hospital and your needs are not too high, they had a team of outreach workers who were then settling people in. Under discharge to assess, it is acceptable to discharge older people, everybody, to hotels if you've not got a home to go to. Workers don't just send the person to the hotel on their own, they'll go with them and they're making sure they're okay. Cornwall is very unusual because it set up 2 residential step-down units, and one of the buildings was a state-of-the-art, fully accessible building. And the problem we see with all the London step-downs, no disabled access. So we've got people with mobility. Joe's been climbing upstairs on her hands and knees because there's
and then coming down on my bum like a child because they're really steep, or they put ramps in, but the ramps are like that. So if there's ice on the ramp, you're coming down it anyway, no matter what you've got in front of you. You know.
So step down, but no disabled facilities here, brilliant. And the other really big achievement of Cornwall's model was in England. We have a very strange thing with separating out care workers, personal care, and housing support. And housing workers are not allowed to do the personal care for people. So if you need washing and dressing, you're stuck. You know, they can take you to the council, but they can't give you a wash. And here they actually got a team of reablement workers on a block contract, so that whether people went on pathway 1 or pathway 2, they would go in and they would provide them with personal care. And what was really special about that was when we talk about a specialist intermediate care service for people who are homeless, it's to do what Mandy's, so it needs to be trauma informed. And these workers, what had been happening before was the reablement workers would go into the person's home and go, oh, she's taking drugs, I'm off. And they'd hand the contracts back, and they couldn't get any carers going in to support trauma-informed support for people with addictions and drug and alcohol. So that was really a supermodel, brilliant. But it was like 2 out of 21 test sites had done the high fidelity. What were the barriers? I'm going to talk about the good practice in a minute, but what were the barriers? What were the problems facing these test sites in trying to replicate this model? And the first real thing is this thing of intermediate care, adult social care is seen as an older people's service. Budget is so tight, they put a lot of barriers in the face of people. If you're under 55 and you're not an older person, you know, it's... And a lot of the nurses, in London, we employed a lot of nurses to go into the discharge hubs, and we called it bear pits, wasn't it? Bear pit, it was like a bear pit. Mm-hmm. If you go in and say to the discharge, please don't discharge Joe, the war, and all the nurses were leaving because that was a site of real interprofessional conflict and dispute. The discharge coordinators, their job, clear the beds, and there's a nurse going, well, Joe just needs to stay another 6 weeks till the housing's ready. So it was huge conflict. And again, in terms of practical things, recruitment and retention was an absolute killer. We'd got all this money to set up all these services, but we couldn't find the specialist nurses, we couldn't find the specialist care workers. So the services are getting going, but it's been a really long haul. And the other big issue is, yes, we got the services up and going, discharge to assess. We've got people in this lovely accessible place, but you can't get a social worker. In Brighton, it was a 6-month wait for an assessment by a social worker. And what we see there then is a lot of warehousing. Yes, people are out of hospital, they've not had an assessment, and they're just there. You know, wasn't there a guy who needed a wheelchair assessment, but he'd been, he was he was going out, and every time he went out, he tipped out of his wheelchair because the OTs had not been to. So it was a real challenge. Oops, I won't bore you with those figures. So why did it work in Cornwall? What was going on in Cornwall that was different? And the first big thing was this is not a short-term funding. Here's funding for 2 years. Integrate services. No, this had been going on for 10 years. Cornwall started this in 2012, and we see a lighthouse effect of short-term funding, things stand up, the money goes, and it all falls away. So it was a long-term thing. Boundary spanning, we were very lucky in Cornwall because the commissioner, she worked with homeless people, but she understood discharge to assess. She was the bridge. So she really understood and got it going. Again, not a housing provider led. The money wasn't just given to a housing organisation and go away and deal with. It was integrated. The council were in the driving seat, and that was the key to accessing the adult social care. And the biggest thing, and the last point that made a difference in Cornwall, was relational commissioning. In a lot of sites, we saw really awful neoliberal managerial contract management, where here's the money, you manage your contract. There it was hands-on. The commissioners that were in there, wasn't it? Peter Oxford, they roll the sleeves up, they're helping, and it's a partnership and a passion, because they want to make the difference, don't they, for people like Joe? Yeah. And that's the difference. It's that passion leads to great integration. I'll shut up now and hand over to my colleague, Michaela.
Thank you, Michelle. It's a pleasure to talk to you all. What we have here now with my presentation, just following from Michelle's, sorry.
Michael, can I just check, are we changing over?
I think that was a yes.
Bear with us, guys, just 2 secs.
Brilliant. Okay, brilliant. So it's just a pleasure to talk to you all. My name is Michela Tinelli. I'm based at London School of Economics, and I'm very much involved in the homelessness project. It's been a kind of a passion of mine for the last 9 years almost, and it's a pleasure to work with Michelle, to work with Joe, and I'm being in charge of the data today. The paper really is looking into what can we do to help services, to help commissioners to improve the experience of people who are homeless and secure better sustainability of services. So really, looking into data, as I said, there are huge gaps in homelessness environment. And in particular, we don't know how people who are homeless value services. And this is crucial. It's very much important to inform better service provision. So different set of stakeholders, so the planners, commissioners, but also the service providers, everybody really, they need to know more about preferences for the homelessness people. They need to inform better design, they need to inform delivery, implementation, sustainability of services. So basically, if Joe wanted to design a step-down house, what it would look like? So this is the sort of questions that we need to answer. So the health economists, they love discrete choice experiments. I don't know whether you're familiar with the technique. It's quite a flexible tool. It allows to measure preferences. It allows you to measure the strength of preferences, attach a value to service provision, different models of care. And this is very much important if you want to bring this sort of information into economic evaluation. So for example, with DCs, you can measure what sort of characteristics patient likes, the trade-off between them, but also what you can measure. You can calculate the probability of uptake in particular model of care, and you can compare different options. So what happened here, really here with our paper, we wanted to use the technique to inform the larger evaluation program. It's been quite a complex exercise. Michelle talked you through all the complexity of our program. But this DC is looking into exploring which sort of elements of this out-of-hospital care model people who are homeless value, and what sort of probability we can have when we model different options of care. And Joe has been very much crucial, helping me each step of the way, collecting loads and loads of questionnaires and making my life easier in a way, because finally I had the data that I want. So basically this is an example of a choice, of a question really, that we embedded in our questionnaire. So every time Joe is asking to people, look, this is a choice. Just compare this scenario where you have returning to rough sleeping versus something else, service A, B, the hypothetical service provision. So in each options you have different characteristics. You have a location, you have main carer, number of visits, length of stay, but also length of care, but also rule, if there is any rule applied to behavior. So these are all the characteristics that we describe as part of the choice. And every time you have the same format, but the levels or the descriptive attached, they might vary. So what happened really is that was a big exercise in co-production with different sets of people, commissioners, service providers. They joined us in different workshop activities, and we reflected together how to phrase the choices, what sort of characteristics were important, the levels and everything. And also we sourced evidence from previous research that Michelle talked to you about. All this sort of information came to me, and we ran a mathematical modeling, and we created a set of choice questions. And what happened really then, with Joe, we did a lot of work in terms of feasibility, going to people, asking them to check our questionnaires, the choice, if everything worked or not. We did different sets of exploration in terms of feasibility, piloting, testing the process of collecting the data, cleaning, analyzing, and everything. So here we are still under, collection. So the project is still underway, but I started analyzing the first 88 questionnaires that arrived to us. Now it's more than 100, thanks to Joe, so a lot of work, but we are getting there. So we are aspiring to 150, 200 questionnaires, so almost there, but still we have some impression from this first set of analysis. So we know the people, we know the majority are male, 48 years of age. 91% of these individuals experience better health exit compared to when they joined the services. We know also about their location, we know about their experience of care, and Michelle already talked to you about different model of discharge and the different experience that these people have with services. So what I did really, I tried to analyze the data, and here are my main messages. So three messages. Message one, respondents do not want to go back to rough sleeping. And this is a big statement. What they want, they love all the different characteristics that we described in the scenario. So everything is valued by them. And firstly, what they like better is the main carer situation. So they want housing support worker in place. So this is the ranking first. And then what happened, they really do value no rules applied to their behavior. They value less visit per week. They want to receive care in their own flat and house, so location is important, and also they value long period of care. So all of these is very much important. So what I did really then with my data, as I said, DCs can help out also in calculating probability of service uptake. So if we start with a scenario of rough sleeping, and you see the description, and we change just one attribute, and we move from rough sleeping to your own home, you see there is a shift and a boost in preferences. So people, they really do love this sort of characteristics and service provision. Again, if we change another attribute, but this time we introduce some rules applied to their behavior, we see that people, they prefer still staying rough sleeping instead of moving in alternative care if some rule to their behavior is applied. So this is hugely valued. Again, if I change multiple characteristics, finally I can picture the preferred model of care, and here we are. So everybody really is willing to move to your own home, housing support worker delivering the majority of the care. The frequency is 3 to 4 times per week, and the period of care is 10 to 12 weeks. No rules apply. So this is the kind of model of care that is highly preferred by the individuals. So just to wrap up, DC for us worked incredibly well, and I need to thank again Jo because she was brilliant, just going around and asking people to complete the questionnaires, and nobody was scared actually of completing these nasty questionnaires.
Well, no, because whenever I go and talk to someone, I always tell them where I was at one stage in my life and where I am now. You know, and they look at me and then they know there's no judgment because I used to be them. So they will open up and tell me everything, and I mean everything. You know, they're honest, they're truthful, and it's not only that. It's like, well, you know, if like being told I couldn't talk to some people because they'd had a drink that morning. Well, I have to say straight, I don't care. If they're willing to speak to me, I want to speak to them. Unless they're falling all over the place when they can't talk properly, then that's understandable. You know, but it's a bit like saying I can't speak to one of yous after you've had a pub lunch or something with a couple of colleagues. You know what I mean? So, and I've had grown men cry and sob because no one ever wants to speak to them. You know?
Unbelievable, yeah. So actually, we managed so far to talk to 30% of all the cohort of people involved in this disease survey. So it's quite a massive achievement considering the struggle that I will mention in a minute. So preliminary analysis, again, the three main messages to take home. First, respondents that do not want to go back rough sleeping. Second big message, all service characteristics are hugely valued, but the three top characteristics are listed here on the screen. And then the third message is that this is the preferred service model they would like to receive. I mentioned a bit of a challenge, so in sample size is still a bit small for me to analyze and do the magic, as people say. There are different struggles for us, in particular the low flow of number of people approaching services. So it takes time to gain the number, and COVID didn't help. All the delays in setting up the implementation either didn't help, but also a lot of the sites closed down, unfortunately. Local services very much under budget, understaffed. So again, they cannot dedicate resources to us, collection of the data. So it's all on Joe really to help out and other members of the team. But really, we are thinking big. We want to scale up the volume, pushing data collection, experimenting other ways of collecting data using platform technology, and eventually having a bigger number where I can run more sophisticated analyses and subgroup analysis as well, because we know that no one size fits all, so we need to investigate a bit better what sort of subgroups works and where. And we want to kind of continue to monitor. We want to aim to long-term evaluations and continuous data collection. And of course, we want to bring all this sort of information from the DC questionnaire together with other information that Michelle mentioned around economics, around outcomes, all together visualized in a dashboard to make this sort of dashboard visualization accessible to the individual service providers, but also to the government to plan better care. So we need a collaboration, we need you, multidisciplinary team with us, and the ambition really is to take this lesson in homelessness and then translate to other environment, other settings, and bring this sort of visualization and evaluation mode reality to support better integrated care. I stop here and just to give you a link to my paper if you want to know about this is you can download the paper. Thank you.
Thank you so much for that. As time is marching on now, I'm going to invite my colleague Alejandro to come up and give his presentation. Over to yourself.
Thank you very much. So thank you very much all for coming. My name is Alejandro Gil. I'm a researcher at the International Foundation for Integrated Care, and I'm going to present the work that we are actually covering in the project CANCERLESS, for cancer prevention and early detection for people experiencing homelessness in Europe. So 2 weeks ago, I was at the National Congress of Social Work and Health, and I've heard like the postcode determines the life expectancy of the population. And I was thinking about this project, and also it was the idea behind this project. Now, what happens when someone has an insecure house situation and they cannot count with the postcode? So, for example, for this project, when we saw the call of the European Commission, because CANCERLESS is an EU project, when we saw the call written by the European Commission, we thought most of the public health programs for cancer screening starts by sending a letter to your home for breast cancer screening, colorectal cancer screening. So there was a part of the population who was excluded from these public health programs. So then we started to look for into the literature, and we found that cancer is the second cause of death in this population. Also, most of the deaths are preventable, but this population, as we have seen, they face a lot of barriers accessing to the healthcare services. Most of them because financial, they are uninsured. They have also the problem if they have a primary, non-assigned a primary care GP, and they go to the emergency department, so they are losing all this part of the care. And also in the political context, actually now the European Commission has approved the Europe Beating Cancer Plan, which is talking about second-class patients in cancer care. So we saw an opportunity at political level, a population who was excluded about all the programs in cancer, and then we decided to look for a potential innovation who could fit here and make some good. And also looking into this situation, we also saw that current healthcare systems, they are also facing shortage of health and care professionals, fragmentation of services. So it was a really difficult scenario, the one that we were facing. But we found the patient navigation, which is a model that is really well known for our colleagues in North America, in the States, and also in Canada. But here is now becoming to be something. Actually, CANCERLESS is the first European project funded with the idea of establishing navigation, a program focusing on navigation in Europe, with the standards, training, goals. Now there are other two, EU Navigate for palliative care and older people in the cancer care, and another one that I will mention later. And we also wanted to focus in patient empowerment, as we saw that was also important for the population. As we were aware that many NGOs, researchers across Europe also, and all the work that was happening in North America existed, the first activity that the consortium conducted was a literature review to double-check all the existing evidence on patient navigation, focused not just in people experiencing homelessness, but also in other vulnerable groups that could also bring some insight to our work. Then we conducted interviews in Spain, Austria, UK, and Greece, the countries that are participating in the project, just to see what were the opportunities to conduct this kind of intervention, what were the main challenges in the local context, And then after the literature review and the interviews, we went to co-design groups with all the knowledge gathered. So we presented to the professionals, people experiencing homelessness, managers, NGOs, healthcare system, oncologists, everyone. So to see how this model should be working, and then we conclude some general conclusions, and then we adapted each plan for its local context. The first thing, what we wanted was also to see what was the professional who should be being the navigator. One of the main conclusions is that these kind of programs can be conducted by professionals, but also for peers, people with lived experience. What we are conducting now in the project is a comparison between pilots. And there are 3 of them that are conducted by professionals. In some of them are social workers, in some of them are nurses, and in one of them are professionals hired by NGOs, but with lived experience also. What we did is to develop a training focusing in population-specific knowledge, communication and interpersonal skills, cancer education, to be aware about what were the cancer screening programs available, risk behaviors, and also the local context and resources, not just to know about the healthcare system, but also to know about what are the assets in the community. So even the training was general, but at the same time tailored to each community. And then the peers and the professionals received the training. And what I think is more important is the tasks and the role that the navigator is developing in its local site. So the main idea behind the health navigator is to remove the barriers for accessing healthcare services. So they are also mobilizing resources for this population to get access to the screening services, but also primary care, primary prevention services. This is based in a person-centered, personalized assessment of the needs of the person. So the navigators are in the social care service. They are reaching this population there. They have an individualized interview with them. They plan with the person what are their goals, their motivations. They are also creating awareness on cancer. So they are facing a lot of fear on cancer. No one wants to talk about cancer. Actually, one of the things that we have faced, and I really like the name CANCERLESS, the acronym, is like people don't want to talk about CANCERLESS because it has the word cancer and they don't want to know anything about the project. So we need to change that in the interviews because they prefer to talk about health navigators instead of CANCERLESS. So they are also promoting awareness in this population, education about self-care, what they can do, for example, for women if they are detecting anything strange in the body, and also because this is an integrated care project, the health navigator also coordinates the resources and the primary and secondary healthcare services. So they are also supporting them to have the appointment. They are also negotiating with the healthcare services also to eliminate the health inequalities and the inequalities in the system, new protocols for population experiencing homelessness, because some of them are facing that they don't have access to a toilet, so they cannot have the test for the colonoscopy, or they don't have a place to keep it. So if they go to the primary care center, they need a place to keep this kind of samples. So it's a complete new process where social and healthcare services are looking for what is not working for this population and creating new ways of working promoted by the health navigator. So what is yet to come? Now, based on the co-adaptation, we are piloting the model in the 4 pilot sites, as I said, UK, Austria, Spain, and Greece. We have created also pilot working teams in each pilot, so they are representatives of all stakeholder groups, navigators, researchers, people experiencing homelessness, primary care services, professionals, but also from the oncology and screening services. So they tell us what's working, what's not working, how they feel about the new intervention, so we can make also adjustments on the pilot. And we are also evaluating it from the sense of the process and also in terms of health output and impact. Also, in the next stage of the project, we are looking for the scalability. We are looking for the blueprint. As maybe have you noticed, I'm focused on prevention on my speech. So the call for funding was just mandatory for us to apply for prevention. But now that we are approaching screening services to this population, we are detecting a lot of numbers of cancers, and they are luckily in early stage, but in some cases not. So we need to create pathways for them, also integrating health and social care services to meet the needs that this population is facing, because how the system works. So the project itself is not creating the intervention for that, but we are looking for creating and propose a care pathway for the local systems. So the next activities that we are going to be developing once we have finished the pilot is going to be a Delphi study to propose standards for an integrated care process pathway for cancer. And with them, we will be proposing 4 different local plans in its pilot, and also policy recommendations at European level on how these inequalities could be faced, also promoting the health navigator model and integrated care. So my last slide. We are really, really happy to announce that we are kicking off a new project. It's going to be co-captain. It's also because we have seen in this short term, almost 1.5 years of CANCERLESS, that the model is really working, and we are in really meaningful conversations collaborating between health and social care services, that when we saw other European calls for primary cancer prevention, we were seeing we started conversations with our partners, and they told us maybe you could go in this direction on mental health. So we have applied for co-captain. We are kicking off next month, so in a few days. And the project is going to be focusing on scaling up the navigation program into mental health and primary prevention. So luckily next year we can present more results of this program on CANCERLESS, but also in mental health, making cancer care, mental health, and primary care more coordinated and promoting continuity in cancer care for this population. So thank you very much. You can find us here. Thank you.
Thank you so much for that. We're now going to go across the pond. Vanessa, can I invite you up? We're now going across to Canada.
Thank you so much. It's such a pleasure to be here. Excuse me. My name is Vanessa Wright, and I'm a nurse practitioner, and I work at a hospital called Women's College Hospital. It's for everybody. It's not just for women, but it was created by women who weren't able to practice during the time that the hospital was opened, back in, I would believe it's around 1910. So I'm presenting a study today on access to healthcare as a human right, a constructivist study exploring the impact and potential of a hospital community-partnered COVID-19 community response team for the Toronto Homeless Service and congregate living setting. I'm also a doctoral student, and I'm exploring the impact of cross-sector collaborative care on organizational learning. I'm a PI of this study. It's a much larger study with many authors. And the study has currently received funding through the Hospital Foundation, and it's a tripart study, so it's one of 3 other studies that are conducted. It's currently been accepted and under revision right now with the BMC Health Services research. So individuals experiencing homelessness face unique physical and mental health challenges, increased morbidity and mortality. In Canada, it's estimated that 235,000 individuals experience homelessness annually, and 180,000 use emergency shelters each night. Emergency shelters in Canada are also known as homelessness shelters, or congregate living facilities, and support a diverse population of women, men, families, youth, newcomers, LGBTQ two-spirit individuals, and the elderly. So there are 53 shelters in the City of Toronto for those who are underhoused, and in addition, there are 7 specific refugee shelters. And I mention the refugee shelters because that's how I've come into this work, is because I'm a primary care clinician and I work in a newcomer clinic, and I also work at one of the refugee shelters, actually 2 of them, 1 day a week, where there's a clinic embedded. So the system is entirely over capacity, and there are significant crowding within the shelters, and of course, the crowding within these shared living spaces creates heightened risk for infectious disease outbreaks. And so this is a picture of some of the shelters in the City of Toronto, and the system is very diverse, and no one shelter is like the other. And the workers are incredibly agile. The shelter workers, they excel at multitasking, all while keeping their clients' needs front and center. I had the great opportunity to work with many of the shelter workers at the height of the pandemic, and I think there's a lot as clinicians that we can learn from this sector. The heightened health risk was certainly demonstrated early in the COVID-19 pandemic when cases of COVID-19 surged among homeless people in Toronto. At one Toronto shelter, 40% of shelter residents tested positive for COVID-19 in a single on-site testing event in April 2020. I was at that event, and it was actually a very scary experience during that time when it was the early phases of COVID-19. People who are homeless also are at risk of more severe outcomes of COVID-19, where they are 20 times more likely to be admitted to a hospital, 10 times more likely to require critical care, and 5 times more likely to die of COVID-19 than those who are housed in Ontario communities. Preventative health measures demonstrate similar health disparity for the underhoused population. In September 2021, 6 months after COVID-19 vaccines have become available to the Ontario population, 61.4% of individuals with a recent history of homelessness had received at least one COVID-19 vaccine, compared to 86.6% of the general population. So in March 2020, Women's College, where I work, set up one of Toronto's 14 COVID-19 assessment centres, also known as CACs, to facilitate and support free testing of COVID-19. This is a picture of, there's sort of 3 pictures here that demonstrate what it looked like at the time. And the COVID-19 response team, which is also known as CRT, was formed by a group of healthcare providers at the hospital as an extension of the CAC, the COVID Assessment Centre. And we know that access to primary care is essential in improving the health of those who are underhoused, yet a survey conducted in 2011 revealed that less than half of Toronto's homeless population identified as having a primary care provider. So despite the foundational role that primary care plays within the healthcare system, it was not identified as a formal platform for the provision of COVID-19 testing, infection control, or vaccinations during this time for the homeless population. So rather, what happened is hospital, community health, and social services joined together and formed a table called the Shelter and Congregate Support Table. And this was spawned by the Regional Health Authority. And it was really in response to the surge of COVID-19 positive cases in homeless shelters. So the primary goal of the CRT, the Community Response Team, was to support Toronto shelters and managing and preventing COVID-19 outbreaks using a comprehensive collaborative model, exploring mobile testing, providing infection prevention and control. And in total, the Community Response Team utilized this model of care for a year, from April 2020 to 2021, and engaged with 49 shelters across the City of Toronto. So over the course of the pandemic, we figured out more as we went along, and geographical boundaries were assigned within the City of Toronto, and Women's College Hospital was assigned to the Midwest part of Toronto, and 14 shelter partners were identified for us as a hospital to work with in a program called the COVID-19 Vaccine Delivery Program. And 10 of these shelters had collaborative relationships with our hospital prior to the pandemic. The Women's College COVID-19 Shelter Program ran for about 6 months and offered first, second, and booster COVID-19 vaccine doses. The clinic frequency ranged from every 1 to 3 months and utilized up to 8 clinicians to administer over 300 vaccines in a single period, or a solo clinician in a single clinic to administer 20 vaccines. In total, 2,300 vaccines were administered across the 14 sites during this period. So studies examining the partnerships between hospital and community have really increased over the past 5 years and suggest that these partnerships hold promise for breaking down silos and improving communication across sectors, as well as ensuring appropriate interventions for specific populations. And this research really seeks to evaluate the impact and importance of this partnership model and its future potential. So the overarching question of this study is, what were the overall perceptions of shelter workers in this hospital-community partnership? And additional questions are, what were the barriers, facilitators, and lessons learned throughout this process? And how can this partnership between the hospital and shelters be sustained in the future to fulfill the needs beyond the COVID-19 pandemic? So epistemically, we approach this research with a health equity orientation, understanding that we have a responsibility as healthcare providers to provide expanded support for under-resourced individuals within the healthcare system. We also believe that the hospital should prioritize community partnerships to identify and deliver care based upon people's needs within their communities served. This research project is located within a constructivist interpretivist paradigm, and all findings are seen as co-creations between the participant and the researcher. So we chose constructivist grounded theory as a qualitative research methodology to explore these perceptions and experiences of this partnership strategy between the hospital and the community, and considering particularly because theoretical data on the perceptions of hospital-community partnerships is limited, particularly in COVID-19. And to promote the ongoing reflexivity throughout this research project, our team carried a strong consideration of the relationships that some of the authors had actually built with the sheltering organizations and a related attachment to this program from the outset. So this research was conducted with staff, administrators from the shelters who we partnered with, and data collection occurred between April and August of 2022, and interviews centered around 3 key themes. So vaccine program evaluation and lessons learned, and number 2, perceptions on hospital-community partnership, and number 3, what are the opportunities forward? So this is a busy slide, but it's just to say that data analysis occurred through 3 stages that it's outlined as constructivist grounded theory. So the first stage is initial coding. The second stage is focused coding, which really allows us to review our codes. And lastly, the authors engaged in theoretical coding, which further conceptualized relationships between codes to partake in the formation of a theory. And this really emerges our core category, which is access to healthcare as a human right, understand our communities. It's important to note, as a demographic overview, 9 out of the 10 shelters served refugees. These facilities also provided services to Indigenous populations and women. It's also important to note that 5 of these shelters had primary clinics on site. And thirdly, there was a diverse referral mechanism to these hospitals, to the hospital vaccine program. Some were self-referred, and others the hospital reached out to as a pre-pandemic partner. And a really important output of this program is that the vaccine uptake ranged between 76% and 100% at these shelters. So this, the data analysis of our research finding revealed 5 main categories, which was formed by 16 subcategories and 1 core category. So this is the complexity of constructivist grounded theory. So this figure is a representation of our findings. The circle in the center is our core category, the 5 circles are the main category, and on the outside is the subcategories. So the core category, access to healthcare as a human right, is a direct quote from our study. The main categories are COVID-19 response capacity, outbreak identification and management, barriers to vaccine program, community-centered immediate shelter needs, and avenues for intersectoral relationship strengthening, and which I will describe further today as some of the main categories explored. So the core category, shelter staff administrators emphasize that access to healthcare is a consistent barrier for the homeless population, and although it's a human right, it emerged as a core category of the study. Overall, participants explained that understanding their diverse communities is a requirement for care partners. Within the pandemic, the barrier to accessing healthcare was exacerbated, but the hospital-based pandemic program helped alleviate some of its negative effects. So now entering into the main categories. In COVID-19 response category, participants assessed the hospital partners' efficiency in supporting their shelter to successfully respond to the pandemic. During a time of confusion around infection prevention control, and information originating from hospitals was seen as credible and trustworthy. As a quote, it said, "It was good to receive COVID-19 information from a hospital. I felt it was more trusted, especially at the beginning of the pandemic, a more trusted source." So during the COVID-19 pandemic, shelters highlighted outbreak identification and management as a primary component of this partnership strategy. Outbreaks were anticipated, yet it was quite unclear how they were to navigate through them despite this hospital partnership strategy. Participants cited limited infrastructure and wait times for test results as contributing factors to isolation challenges. As a quote, "The results at the hospital partners testing site took a very long time. It was a challenge for congregate settings because we don't know what to do when we don't know what the results for a couple days." And that's really referring to isolation challenges and placement of their clients that are on site. So this category, barriers to the vaccine program, refers to the ways in which the program was inaccessible for the shelter population. In addition to the frustrating wait times that they described, there were four main additional issues that were highlighted. Inconsistent testing schedules, barriers to vaccine delivery, structural barriers for specific populations, and vaccine hesitancy. These issues play out against a backdrop of ongoing systemic issues within the country's healthcare environment. So although no individual hospital or program may fix a structural issue, it is important to consider where special attention may be required when designing and carrying out such programs. While speaking to participants about the efficiency of the vaccine program, several unaddressed urgent shelter needs emerged that highlighted existing gaps that compounded shelter's day-to-day pandemic requirements. As a request for continuing pandemic support speaks to the unclear COVID-19 protocols that particularly emerged during the fourth and the fifth wave of the pandemic. And in addition, there was requests for mental health crisis support and intervention on site that was related to the increased number of crisis incidents that were felt and experienced by shelter providers during the pandemic. And thirdly, the healthcare system navigation and access support are really noted because individuals commented that often their clients were inappropriately discharged from hospitals to shelters. So the primary focus of many shelters lies in housing, and there's often little attention placed on health resourcing, solidifying partnerships, accountability, and governance structures. Recognizing this and working towards geographical alignment with health partners to meet these immediate shelter needs is essential in keeping communities' needs at the center of these hospital community partnerships. And lastly, community hospital partnerships are required for sustainable change, commitment, and lasting support. And four pivotal avenues were shared by participants. Health advocacy for their clients without health insurance, information sharing tables that were formalized, official partnerships that were also formalized, and educating health professionals about systemic health inequities. And as a quote, I found this really interesting. And one of the workers had said, "In addition to the direct relationships, all of the refugee organizations have a really strong network and collaborate amongst us. When you think about collaboration between the hospital partner and the community, think more broadly than just individual organizations, but think of us as a whole collective." I thought that was really fascinating because it's the paradigm of how they're viewing healthcare and their health service delivery, which is quite different from what the hospital actually delivers or thinks of their delivering. So shelters want hospital engagement on a quarterly basis to check in, ask about evolving health needs, share relevant information that could support communities' health needs. And at the time, monkeypox was really prevalent, and they were asking for further information, infection, and control support. And there's a really need for formalized partnerships, as this came up, that demonstrates a level of commitment that communities can expect from hospitals and certainly provides a means of accountability. So in conclusion, this hospital-based pandemic program demonstrates the importance of centering community voices in hospital-based community programs, as well as the breadth of knowledge that's certainly gained by service providers when doing so. These findings should be taken into consideration when planning future hospital programs, with the recognition that the perspectives of shelter populations may differ depending on demographic context and location. And at a high of time anxiety and many health unknowns, the hospital was viewed as a trusted source of information, and this partnership model certainly provided benefits to siloed shelters without many institutional supports. Hospital-based community programs in collaboration with shelters can alleviate some of the ongoing health concerns faced by the shelter population during a time of COVID-19 or not. In preparation for future pandemics and unanticipated health emergencies, access to care and cohesion within the health system requires continuous engagement in relationship building between hospitals and communities to support co-creation of innovative models of care and promote health for all. Thank you.
We're hearing such powerful presentations, and the synergies are really beginning to run through. I'd like to invite Isla and Lynn up onto the stage for our final presentation. Can I just say, in the interest of time, I'm really sorry, we're not going to have time for questions for folk who are online. Our presenters will be asked to look at any of the questions that are posed to get back to you, and everybody here, please stay with us for our last presentation and follow up with the presenters who will be here throughout the conference. Thank you. Over to yourself.
Good afternoon, everybody. I'm a bit of a warm-up act for my colleague here. My name is Lynn Topham. I'm a locality manager, and I'm here with Dr. Isla Kosh, GP and clinical lead for a service called Cardiff and Vale Health Inclusion Service, as we call it, CAVIS for short. We work for the University Hospital of Wales in Cardiff, which is the capital city of Wales. The city serves about 500,000 in terms of population, and it is organised into 3 locality areas. The demographics of the 3 localities is quite different. There are areas of rurality and wealth, areas that are populated by significant levels of older people, and then there's the city centre area, which serves a very diverse population in terms of culture, transient populations such as Roma Gypsy travellers, asylum seekers and refugees. We have people engaged in sex work and the homeless. In addition, the city also hosts HMP Cardiff, which is a Category B remand prison with a maximum capacity of 770 men, many of whom are released into homelessness. We're here today to provide you with an overview of the work that we are progressing in relation to meeting the needs of people with multiple disadvantage living in our area, which is Cardiff South and East locality. This work is predicated upon multi-agency and integrated working across the Health Board, our local councils and our third sector organisations. And it involves the development of a shared vision, alignment of organisational strategies and maximising opportunities to influence at both a local and national level within Wales. Although we are at an early stage of development, our aim is to provide a comprehensive, tiered model of healthcare for people residing in our area who are experiencing multi-disadvantage and who require an integrated approach to ensure access to the care they require. I'm now going to pass over to Isla, who's going to provide you with more detail in terms of the context and the aspirations that we have for the future.
Thank you, Lynn. Thank you, Lynn. Okay. So I'm just going to take you on a bit of a journey, as Lynn said, as to where we've been, where we are now, and then where we want to go in the future. So, a bit of context. We know that the traditional model of primary care that we have in Cardiff and Vale doesn't really address the needs of people with multiple exclusion. So this current model is leading to really poor health outcomes. All-cause mortality is much higher in multiply excluded groups. We know that the average age of death for men experiencing homelessness is 48 and it's 43 for women, which is a shocking statistic, isn't it? And mortality is much higher for women engaged in active sex work and again higher in the year following prison release. So those are really stark statistics. As well as poor health outcomes, we know that there's this current model is really driving a lack of trust. So when people can't get their needs met repeatedly, relationships break down and then they end up not bothering to access the care that they need. As well as this, we've got really long-term escalating costs. So the fact that money isn't put where there's the most need doesn't actually save money in the long term. It leads to actually healthcare being more expensive. So this statistic at the bottom is from Public Health Wales, which showed that during the year 2020, over a 6-month period, £11 million more was spent on people who are homeless using the EU A&E than the general comparator population. So the system that we've got isn't saving money either, it's not meeting anyone's needs. Again, a bit more context. This data is from Public Health Wales, which shows, to the left of the slide, that actually over the last 10 years across Wales, inequalities in life expectancy are actually increasing between those in the most and the least deprived. And to the right, this stat is from Cardiff and Vale, so more local. It shows that inequalities in healthy life expectancy is remaining stable. So although it's not getting worse, it's not getting better. So this slide is probably familiar to a lot of you. This was published by UCL in the Lancet a few years ago and shows standardised mortality up the side mapped against deprivation. So if you look, it's got a very gentle slope, hasn't it? A gentle slope of inequality from the least deprived to the most deprived. So as you go further up the deprivation scale, mortality goes up. If you map excluded groups onto this, then it goes off the scale, and that has been coined as the cliff edge of inequity. So I'm showing you this to try and illustrate where CAVIS, our health inclusion service, is trying to target its resources. So the people that are experiencing the worst health outcomes fall into the groups that Lynn already mentioned. So people seeking asylum or people coming via refugee resettlement programs, people experiencing homelessness, people engaged in sex work, people having just left prison, and Roma, Gypsy and travelling people. So that's the context. What did we do? Well, the clinicians in the service and the managers recognise the need that we need a bit of remodelling of primary and intermediary care from the perspective of the individuals that access the services to try and redress the extreme inequity. And we recognise the need for a specific health needs assessment in our local area. So we collaborated with our public health colleagues and we did this health needs assessment. So we used the usual methodology, so epidemiological. We gathered lots of data from local and national sources and did a bit of a rapid review. We conducted lots of surveys with stakeholders, but also with service users in each of the 5 excluded groups. And then we compared the data and the stakeholder interviews with other areas across the UK doing similar work. All those findings were synthesised into a bit of a gap analysis, and then this was used to create an action plan. So very briefly, some brief highlights. This is obvious, really. The health highlights that were identified were around mental health, particularly around traumatic stress and substance misuse. There was a real problem with accessing dental care, sexual health and infectious disease such as BBV services, and complex case management was something that was also raised. So that was the health. And then within the social care bit, it was housing, employment, income security and community and peer support. So we also asked people about barriers and facilitators to accessing primary care. And again, this won't be a surprise to you in the room. So barriers were the stigma and discrimination, which is rife in our services, a lack of trauma awareness in the services that provide the care, which someone mentioned earlier, really inflexible service models. So primary care having 10-minute appointments very rigidly, opening at 8 a.m, closing at 6 p.m, and you have to turn up within sort of 10 minutes of your appointment, otherwise you may not be seen if you're late. So that kind of rigidity doesn't work with these patient populations. Lack of continuity of care, language and literacy barriers, and often street-based lifestyles, which again don't really go with the formality of the care provision, and a lot of fragmentation of services. So we just found that people were falling through the gaps. If there was a referral to be made, it would be very low chance that person would actually make it to that service. So, wasting everybody's time, and then the person's not getting the care that they need. And then we identified really a lack of dedicated strategy for health inclusion overall. So facilitators, again, not a surprise. Staff friendliness, I know that's really, really simple, but actually it's hugely, hugely important and effective. But I think from our stakeholder interviews, what we found that traditional services were under such pressure that often there wasn't the time to deliver the care that people wanted to deliver. So it's not like people in traditional services are anti-excluded groups, it's just that the system creates this environment for which they're not able to care as they'd like. Case management and advocacy was identified as a really good facilitator for access, and flexible care models. People wanted to be able to access the care when they needed it, on their terms, and in an environment which they felt safe and comfortable. Knowing individual case histories was important, which is about continuity of care, and stable housing. So, how can somebody living on the streets or in a difficult hostel environment access care off their own back? It's extremely difficult. So stable housing is a massive facilitator, as you know, to accessing care. Co-location of services. So currently in Cardiff, there are many services, but often some of them are across the other side of the city. And so we expect people to pay ever-increasing bus fare charges to get from one place to another, and it's just not practical at all. And inclusion health plans, that was identified as a facilitator. So these quotes at the bottom were from people that I know. The quote in red, I can picture this woman's face. So she said that her drugs and sex work came hand in hand, but the doctors wouldn't listen to my problems. They'd just blame the drugs and lifestyle. And it got to the part where I didn't bother going anymore. What's the point when no one listens? So this just illustrates the extreme relationship breakdown that I mentioned earlier. So our public health colleagues came up with some very high-level recommendations for us. So these were around addressing leadership structures, including inclusion health into strategic plans going forward, increasing complex case management, those sorts of things. But what we wanted to do as a service was to come up with some tangible, very practical differences that we could do there and then on the ground whilst we worked on our bigger overall picture and direction. So we decided to try and pilot some GP outreach clinics at high needs hostels, and the aim was to provide timely care for acute needs. So we didn't take over full care. They retained their GMS registration with practices, but we were trying to facilitate access to emergency care. And not only was it trying to facilitate access for them, but it was trying to reduce the pressure on unscheduled care. So we know that people experiencing homelessness find it difficult to access primary care. So generally what happens is that they will leave the health issue and leave it until it gets to a crisis point where often it involves admission and potentially an ITU admission, so costing loads and loads. That's one path. Or the other path is going to use the EU as primary care, and then they're discharged or turned away and they don't even get their needs met there, so there's no preventative care going on. So those are the things that we wanted to tackle. There are 4 high needs hostels across Cardiff. There are lots of hostels, but 4 very high needs ones, that we put a GP into each one of those once a day. If someone lived in a different hostel, they could come to the hostel where the clinic was being run. So we were really open and flexible. And then we collected data after 3 months to evaluate it. So we had at least 146 consultations, most of which were men. Our mean age was 40, and most of the conditions that we were seeing were around skin infections, ulcers, injuries, and common respiratory infections. We asked our clinicians who were seeing the patients when they did the data collection to try and document whether they thought that consultation had prevented somebody turning up at the EU, and it was found that nearly half of the consultations prevented that journey, which I think is massively successful. So it didn't mean that everybody stayed away from hospital. What it meant that people got treated for things that didn't need to go into hospital, but for those that did need to go in for various things, we tried to bypass the EU to avoid that waiting for 18 hours, going through opiate or alcohol withdrawal, the cycle of discharge, and then representing again the next day in worse health. So it was very successful for that. Got 4 main key learning points, I think, from our experience so far. So firstly, it's really the importance of starting with population health in our local context. So we knew anecdotally that those 5 groups have the poorest health outcomes, but it was really, really helpful to work with public health colleagues to actually have this defined as a firmer foundation from which to do further work. Shared values and vision has been really highlighted as important. So we work quite closely with Cardiff Council to try and develop medical rooms in each of the high needs hostels, to work with the hostel workers and develop good relationships there. And it's gone really, really well. And they've come with lots of ideas for us, which we want to take forward around IT and online consultations. So we're now thinking about setting up computers in various hostels to do online consultations, and that might be successful, we're not sure. So that was good. Thirdly, stronger alliances. So particularly with our third sector colleagues. So all our stakeholder interviews and interviews with service users, we couldn't actually have done without our third sector colleagues, because they had brilliant relationships with the service users, and it wouldn't have been any good me going up to a group of sex workers going into parlours and saying, do you want to fill in my form with my clipboard? It had to be via third sector, who already had the relationships of trust there, and that was brilliant. And we've piggybacked onto their hard work, and we're working to try and develop those relationships more. And fourthly, I think it's really highlighted the need for system-wide governance and leadership. The level of inequity and exclusion that's out there cannot be solved by health alone. It can't be solved by social care or third sector alone, but we have to come together, don't we, as cross-sector partners in a system-wide approach to really try and tackle it going forward. So that's what we learned, and here's where we are. But what next for us? So we've had established a health inclusion programme board, which we're really pleased about, with the aspiration of developing a centre of excellence for health inclusion in Cardiff, which may be able to be spread and scaled across Wales. So this centre of excellence, the hope is it will also include a dedicated GMS practice or health inclusion practice, where people from those groups can come and get their needs met, and we will be their main provider of primary care. And the idea is that model will be developed from the perspective of the person in a co-produced way as well. So we're working with partners to try and get that up and running. So just to finish, this is the emerging model. This isn't set in stone. I'm very happy for this to be changed as we go along and talk to more people. So the idea is that it is a hub and spoke model. So at the top on the left, we've got entry into the service for the 5 groups that I've identified. And then the self-referral, the referral mechanisms could be through self-referral. We could have referrals through the EU if people turn up there, through the Home Office, as we already do for the bit of work that we do with the people seeking asylum, homeless MDT or third sector. Basically, there's no wrong door approach. On entry to the service, we hope to provide a psychological formulation for people so that we can better plan the care, a full health and oral health needs assessment, and a housing and social care needs assessment as well. And as we're already providing is any catch-up vaccinations, Hep B vaccinations, and GMS care. If at this point we deem people, or they deem themselves to be stable and not in need of our services going forward, then the idea is that we would help them register in traditional services or potentially step-down services. But if they do need to stay with us, they would have access to all these co-located services, so our partners in health, but also in social care, third sector as well. And then as well as the hub, we've got 2 spokes. So one spoke is the outreach model, which we're already doing a little bit of with the homeless outreach, but we also hope to outreach into probation services, potentially campsites and the streets for those people who are really entrenched and find it really difficult to come in from the streets. And the other spoke is an in-reach pathway. So we're looking at piloting having a homelessness in the EU to meet anyone that comes in who's homeless and try and fast track them through the system to avoid the long traumatic waits and withdrawal for those who are addicted to opiates. As well as the EU pilot, we're looking to try and get in-reach into hospitals so we can facilitate more holistic discharge planning to then prevent that cycle of readmission because people are discharged into unsuitable accommodation, as we've already heard. So it's been brilliant to be here because I've just learned so much from the other speakers, which I'd like to link up with later, that this is our aspiration. And we've done loads of work. There's still loads more to do, but I think we all really feel that it's a matter of justice, really, that models of care are changed and move forward for these people. So thank you for listening.
Guys, thank you so much for that. For those of you joining us online, I think summing this up, what comes to mind for me is active listening, openness, heart, relationships, and innovation through co-production and co-design with the person at the centre. So thank you so much. If you're coming to the dinner tonight, if you're here in person, we'll see you there. If not, enjoy your evening. Thank you so much for your patience.